We are going to give one more minute to let folks join in on the call, and then we will dive right in. Thank you again. We really appreciate y'all being here. All right. We're still seeing those numbers tick up a bit of folks joining in, but it seems like it's beginning to level off there a little bit. We'll go ahead and get started. Hey, everyone. Thank you so much for being with us this afternoon. My name is Julie. My pronouns are she, her, and I work at NACHO, looks like Nacho. It's the National Association of County and City Health Officials. I'm a senior program analyst with our harm reduction portfolio here. And we really just want to thank you for being here. Today, we are going to do an hour and a half, which seems like a long time, but for this topic, it really is just like the tip of the iceberg and how deep this can go. And we're so thankful that there's a 5-part series on drug user health and syphilis because it is incredibly needed. And we really do just appreciate everyone being here today. So today's webinar is You Can't Screen Who Won't Come In, taking a harm reduction and whole person approach to care for pregnant people who use drugs and promising practices. And we will move to the next slide. I do just want to shout out AIDS United, NASDAD, National Coalition for STD Directors, and the Northwest Portland Area Indian Health Board, who have been active partners in this project as well. So thank you, thank you, thank you. And next slide, please. So a couple of housekeeping things going into it. This webinar is being recorded. So the recording and the slides will be emailed to everyone who registered. Lines are muted to ensure the quality and the flow of the conversations here. We are going to hold all Q&A until the end of the presentations. That doesn't mean if you don't have a question that you are thinking of as the presenter goes on, you can feel free to put those in the chat box, but those will be answered at the end of the webinar and giving all speakers a chance to address that. We are hoping to have a good solid 20-30 minutes worth of discussion there. Again, feel free to ask questions at any time and put those in the chat box. If we don't get to a question during the interview, we will work on responding to that in a follow-up email. And your questions and your feedback are much appreciated. Also, at the end of this, we will have we'll also have a couple of quick polling questions for everybody as well. All right, and next slide. Yeah, so we are gonna we thank you all for being here. We have a few speakers who are going to be with us today. I'm going to provide a very quick overview of pregnancy, of substance use, pregnancy, and syphilis. We'll move into what is reproductive harm reduction, and then recovery and reentry, substance use during perinatal care period and care engagement, and then medication-assisted treatment and substance use disorder in pregnancy. Our speakers are from the Academy of Perinatal Harm Reduction, University of North Carolina Horizons program, and the Florida Department of Health in Citrus County. And we are very, very excited to have all of our speakers on today. And next slide. We want to also just say a few notes. We know that, language is malleable, it is adaptive, it is growing to adapt to all the folks who are impacted by this. There will be some studies, and then there will be some vocabulary that is targeted specifically. Largely, we know that ends up being towards cisgendered women, but we recognize that not every person who's capable of pregnancy is a woman, and not every woman is capable of pregnancy. We also recognize that not every person who uses substances has a substance use disorder or wants to end that substance use. And then lastly, people who use drugs are not inherently unfit parents, nor are they ambivalent about the care, about their pregnancy or their desire for a healthy birth. We also recognize people who use drugs, as all people are not a monolith. And there isn't a one size fits all that's going to work for every person. And next slide. So just doing a very quick overview on substance use, pregnancy, and syphilis. So congenital syphilis, which is what we'll largely be discussing today, occurs when syphilis is passed from a pregnant person to their fetus. It's preventable when pregnant folks are screened and treated in a timely manner. From the reason that we're having this conversation is that we've seen a really, really huge increase both in syphilis of people writ large, but also among pregnant people and to their fetuses. So from 2015 to 2019, the rate of primary and secondary syphilis among females from 14 to age 44 increased 171.9%. Congenital syphilis rates increased 291% during that same period. Congenital syphilis can lead to pregnancy complications as well as stillbirth, as well as some early developmental issues for the child. CDC recommends screening for syphilis during pregnancy at a person's first prenatal visit and then again at 28 weeks. In areas where there are high rates of syphilis or individuals with certain risk factors, which we'll discuss later, it is recommended to then screen again at delivery. Next slide. So studies have also found that pregnant people who use drugs or have a history of substance use are more vulnerable to more vulnerable to syphilis infections. Other vulnerabilities for syphilis infection include transactional sex, incarceration of either the person who's pregnant or their partner, unstable housing or being unhoused. Pregnant people who use drugs are also much more likely to delay or not receive prenatal care. So when we think about what those recommendations are for syphilis screening, we aren't able to screen that person and provide them with that appropriate care if they have delayed that care and are unable to get the treatment that they deserve and need. Factors can include accessible care, housing instability, stigma, distrust, and criminalization of people who use drugs. Next slide. So congenital syphilis disproportionately impacts racially and ethnically marginalized people. According to the National Institutes of Health in 2018, 44.4% of congenital syphilis births were among African American or Black women or people, 32.6% among Hispanic or Latinx pregnant people, 22.7% among white pregnant people. So we see this disproportionately impacting people of color. We also know that from 2014 to 2018, rates of congenital syphilis increased 500% among American Indian or Alaska Native people. And that increased from 13.2 to 79.2 cases per life per 100,000 live births. And in 2018, the case of reported congenital syphilis among American Indian or Alaska Native people were 5.9 times the rate among white folks. And we'll move to the next slide. So this is kind of my last final wrap up of this. So pregnant people, pregnancy can be a really amazing opportunity for people to have care in ways that typically aren't available to them. So folks will oftentimes qualify for Medicaid who maybe didn't qualify for Medicaid before. And it can be an opportunity to provide folks with a broad spectrum of health and wellness needs. But if a pregnant person fears criminalization, they are not going to be able to access many of these vital services, including treatment for syphilis. From the year 2000 to 2015, the number of states with laws or policies that criminalize substance use during pregnancy increased from 12 to 25. About half of all states require that healthcare professionals report suspected substance use of pregnant patients. We know that this has also changed, and that we are working on keeping up with the most up-to-date legal rules around this. We also, in a study on neonatal abstinence syndrome, they found that states who have these punitive policies that criminalize pregnant drug users had higher rates of neonatal abstinence syndrome than states who did not have those policies. And they stated that pregnant people who use drugs are disengaging from healthcare systems in states where punitive policies regarding substance use during pregnancy have been enacted. So these policies prevent people from seeking and receiving the treatment that they deserve during their pregnancy. And next slide. And with that, very quick and dirty overview of everything, I am going to pass this over to Joelle Ficcio from the Academy of Perinatal Harm Reduction. Thank you so much, everyone.
Thank you so much, Julie. Um, so I want to leave so much time for the other presenters who I'm just dying to hear, and also for questions. So I'm going to dive right in. Um, you can go to the next slide. I'm going to move kind of quickly through this content because there's a lot to cover. So please, if there are questions or you want me to expand on any ideas, just pop that in the chat and we will get to those at the end. Basically, this is my intro slide. The short story is I've been doing this for a very long time in multiple contexts. I am the co-founder of Academy of Perinatal Harm Reduction. Next slide, please. And our mission is very broad and very targeted. We just want to do anything we can to improve the lives of pregnant and parenting people who use substances. So with COVID, our in-person stuff kind of took a back seat. So for the last few years, we've been really focusing on changing the narrative and talking about evidence-based information about substances. We want to create communities for all of us to live in as well, where families are safe, intact, and informed, regardless of what they choose to put into their bodies, whether that is sperm or illicit substances. Next slide, please. I want to do a quick plug for the toolkit. I accidentally put this slide twice. If you have access to the slides, there is a link embedded in the PDF where you can access the Pregnancy and Substance Use Toolkit. It covers 6 classes of substances, prenatal care, pain control, and a whole lot more. Next slide. I don't have any financial relationships. If you would like to have one with me, please let me know. I would be so down. Next slide. So we're going to start with just a basic overview of harm reduction. I think most of the folks on this call have an idea of this, but I want to make sure everybody's on the same page and you know what I'm talking about when I'm talking about harm reduction. Next slide. So the most common example that I hear is that harm reduction is just reducing harm, and it's something that we all do every day in our lives. We know that riding in cars and buses and traffic, being near traffic is one of the most dangerous things a person can do in this country. But rather than attempting to eliminate all car travel, we instead take measures to make it reasonably safe. So we have seatbelts and stoplights, and we paint lines on the road to tell you where to drive and all these types of things. That is what harm reduction is. It's accepting that there is a certain amount of risk in day-to-day life, which drug use is a part of day-to-day life for most of us, if not all of us. And just doing what we can to make life safer for all of us and the people around us. Next slide. Another really great quote that I love is from Voltaire. I'm not going to read you the French, but basically, perfect is the enemy of good. So if in your practice or in your clinic or wherever you're at, if the only acceptable outcome is perfection, you're going to be both ineffective and just really disappointed all the time, because that's not going to happen. So what we can do to adjust our thinking about this for substance use and so many other things in our lives is to strive for perfection while celebrating every step along the way, celebrating the good and not just the perfect. Next slide. So basically, all definitions of harm reduction include 3 key elements. There's really good ones from Harm Reduction International, National Harm Reduction Coalition here in New York, and various other orgs. But the 3 main points are that we respect people who use drugs. And this one is really hard, especially when we're thinking about healthcare, because we all come at it with an agenda, like, I want you to not have syphilis. But that's not going to be helpful in our interactions with our patients and our clients. We need to ask people what they want and respect their choices and their values and their decisions. Second, we want to improve the quality of life for people who use drugs as defined by them. So perhaps your primary goal might be, syphilis reduction, but this person standing in front of you, their primary goal might be getting a new prescription for their glasses so they can see and read and find work and function in the universe, right? And then finally, and not least importantly, we want to promote joy and pleasure, because so often when we're talking about substance use, we get hung up on associated dangers and risks and what we can do to reduce harm, right? It's right there in the name. But we also want to acknowledge that people use drugs for reasons, because they work, at least at first, because they feel good, because they make us better at socializing. And so we want to make sure that we acknowledge and promote joy and pleasure instead of just ignoring it. Next slide. A couple catchphrases, if you will, in harm reduction that I really think just encapsulate what we're talking about. The first one is any positive change. This was popularized, of course, by the great Dan Big at Chicago Recovery Alliance. And basically, it's just what it says. Any positive change, no matter how small, is cause for celebration. So if you have a patient or a client who is still, drinking a 12-pack of beer every single day, but they stopped driving drunk, woohoo, celebration. That is fantastic. When we celebrate small changes, then it helps our people to build the self-confidence and efficacy that they need to tackle the next challenge. Next slide. The next one that you'll hear often in harm reduction is meeting people where they're at. And I love this one because it works on so many levels. That can be literally meeting people where they're using drugs. Like in the photos, Dance Safe goes to like festivals and like EDM parties and stuff, doing drug testing and safety teaching. Or Chris Abert there in a parking lot. We go to where people are because that's where they need the services. We can also think of this more philosophically. Like if you're trying to talk to somebody who doesn't really, empathy's not working on this person, then you meet them where their values are. So maybe they want to talk about how harm reduction is fantastic for cost reduction or reducing your vulnerability to lawsuits for maltreating your patients. There are so many different places that we can meet people and talk about harm reduction because it works for literally everything. Like there's no sphere or argument where harm reduction is bad. Like harm promotion, like no, harm reduction works for everything. So even if we would like everybody in the world to be empathetic and to view people who use drugs as whole people capable of making decisions for their own selves, if they don't, we can still meet them where they are philosophically and work with them and talk to them. Next slide. I want to be in the chat right now. I'm like jealous that I'm presenting. Anyway, so we'll talk a little bit about language. Language is so important because it not only helps us shape our own thoughts, but it communicates to the world how we feel about certain things. The choices of words that we use when we're talking about people who use drugs and their children can really make a huge difference in whether somebody views you as a safe place to receive care or as a threat. So I'll just pull one out. We don't really like to use the word addict or addiction. Firstly, this has been identified as hate speech by people who use drugs. Secondly, it is not a medical diagnosis and hasn't been for several decades. DSM-5 uses person with substance use disorder. So it could be substance use disorder, or it could be more specific like opioid use disorder. We don't talk about babies as being addicted, even way back, before most of you probably were born. Addiction never referred to anything that a baby could do. It's a set of behaviors such as neglecting responsibilities and drug seeking. Babies can't do that. They don't have responsibilities. They don't really have a whole lot of agency. So we talk about babies with either exposure or physiological dependence. Next slide. When we're thinking about reducing harms for people who use drugs experiencing pregnancy, most of what threatens their lives, their health, and their families is not really related to drug use all that much. If you look on the slide there, we are looking at criminalization. We're looking at lack of resources, lack of access to healthy food, lack of access to care, environmental degradation, mental health issues, trauma. All of these things intersect and combine to cause risk of harm for pregnant and parenting people. Next slide. So when we're talking about harm reduction, we're not just talking about clean needles and alcohol swabs, although we are talking about that. But we also need to think about the person's whole health. So we need to think about nutrition, transportation to work, to healthcare clinic appointments, accessibility of those spaces, both for people who speak other languages than English as a first language, people with mobility issues, and again, people with trauma, which we're going to talk about a little bit later. I've seen a couple doulas in the crowd, shout out. Doulas are harm reduction. I wish everybody who accessed any kind of healthcare had a doula, because it's so exhausting and so difficult, but especially people experiencing pregnancy with substance use. Next slide. So we're going to talk a little bit about the history of how we got to where we are, and then we'll talk about where we are. There have been two distinct narratives about women and substance use that you can still find currently now. So one of those was aimed at kind of middle class white women who were primarily in the home. Laudanum, morphine, other opioid, snake oil remedies, most of them, were heavily marketed to women and children. Opioids are really good medicines. So especially back in the day, like in the 1800s, diarrhea type illnesses were really common killers of young children. So it was very, very good for drying up diarrhea. It's very good for the various types of pain that people still don't want to research related to people who have uteruses, such as polycystic ovary syndrome and things like that. However, I think the real reason that it was so heavily marketed to women is because of its power to sedate and tranquilize. Your wife getting too mouthy, give her some laudanum. That'll shut her up, right? Next slide. So on the other side, we have this attitude towards women that are not sedate and tranquil, who perhaps leave the home without a male supervisor, who may possibly have contact with men outside the home, particularly men of color. I could talk about this for several hours, the intersections of racism and misogyny in our drug law, but I'm just going to pull out this one example from mostly in West Coast San Francisco, but these types of laws spread all the way across the country. Outlawing wearing your hair in a ponytail, outlawing smoked opium, but not eaten or injected opium. These are particular laws targeted at a particular type of person. Once you start digging in, it is extremely obvious that this has nothing to do with opium or opioids. These are targeted racist laws against Chinese immigrants. And women were often used as a token in these types of arguments. We have to keep the Asian men from accessing our pure white women. Next slide. So fast forward to about the 1980s, and forgive me, I'm not going in chronological order. We have the crack baby scare. So in the 1980s, Ronald Reagan and various other folks kind of popularized this idea that if you are exposed to crack cocaine specifically, not powder cocaine, during pregnancy, then you're going to be born with like 3 arms or, half your brain missing or something. And we all kind of absorbed these ideas, which were not based on fact at all. In fact, the doctor Ira Chasnoff, who originally published the data on crack exposure in pregnancy, later tried to walk back his overzealous conclusions, but by then the damage was done. This also, not coincidentally, coincided with the stereotype of the welfare queen. Both stereotypes of the crack baby and the welfare queen were highly racialized, and we were taught to expect that people who were embodied one of these stereotypes were brown and black, particularly black. This is a great video. I believe it is linked in the slides. It's only about 9 minutes, and it kind of goes over that history. Highly recommend. Next slide. So just in case anybody thought that these things, that these policies are the result of of good intentions and they're just unforeseen consequences, and how could we have known? I'm going to read you this quote. This is from John Ehrlichman, who was a top advisor for Nixon during the very, very early days of the so-called war on drugs. It was actually a war on people who use drugs. And Juan, when I get to the end of the quote, the second half of it is on the next slide. So please just flow through if you would. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or black, but by getting the public to associate the hippies with marijuana and blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. Of course they did. There have been multiple government commissioned reports since the 1930s that have been saying, you're doing it wrong, stop it. But our politicians and our leaders just keep ignoring that. Next slide. Once you start seeing the racially and gender motivations of drug laws, you can't unsee it. You'll just see it everywhere. So these days, what do we have? I'm going to give a couple examples of the ways that that things actually happen in the world, as opposed to the way they're supposed to. So we have fetal assault laws. The intent of these laws, supposedly, is to inflict harsher punishments on somebody who hurts a pregnant person. What actually happens is that pregnant people are prosecuted under the laws that are ostensibly created to protect them for using illicit substances or attempting medication abortion. I've even seen some ridiculous ones, like somebody got prosecuted for not wearing a seatbelt while driving while pregnant, with, attempted manslaughter, like not just the not wearing a seatbelt fine. Charges of murder and decades-long prison sentences are super common. And this is just continually happening. Right now, there's a case in California, Kelsey Carpenter, who suffered a miscarriage and had a history of substance use and is currently in prison away from her two small children, and facing this extremely long sentence, possibly life in prison. Next slide. So we're in this kind of environment where we blame pregnant people for not producing a perfect, healthy baby at the end of pregnancy. However, it's very selectively applied. Our safety for pregnant people and newborns in this country is pretty dismal. Just a few stats. We see birth defects in about 3% of pregnancies. So that's about 1 in 30 children is born with some kind of birth defect. Miscarriage occurs 6 to 20% of the time, depending on who you ask and how you define miscarriage. I kind of just pregnancy loss in general, stillbirth, miscarriage lumped together for those stats. So that's up to 1 in 5. And our maternal death rates are higher than any other country with an industrialized medical system. So what we're seeing is people that are suffering from expected negative outcomes are being blamed on drugs. And that's something that I think is very embedded in healthcare. Once we know that drug use is happening, we stop looking. We're like, oh, that's what it must be. Even though most drugs are not linked to birth defects or necessarily negative pregnancy outcomes. There is no evidence to support these kinds of charges. And additionally, it's these charges create a class of crime that can only be committed by people with the capacity for pregnancy, which is inherently gender and sex discrimination. Next slide. So when we're thinking about reproductive harm reduction, it's basically a blend of reproductive justice and liberatory harm reduction. We know that there are intersections between multiple identities, and sorry, I'm distracted by the chat. Yeah, that picture's from The Onion, but it's so good, right? Anyway, there are intersections. Nobody's just one thing. Nobody is just their drug use. Nobody is just their pregnancy. However, despite this, at most harm reduction programs, reproductive services are condoms, HIV and Hep C testing, and the end, right? We don't think about the needs of people who have the capacity for pregnant or the needs of people of any gender who have small children. Next slide. So I'm going to touch on trauma-informed care very briefly to make the main point that most people who use substances have experienced trauma, abuse, and violence at the hands of healthcare providers. So the fact that someone is standing in front of you is already an act of tremendous courage and bravery and should be supported. Like the title of this today, if you don't make people feel welcome, they will not come back. Next slide. Hopefully this is not news to anybody, but you don't need to know the details of someone's trauma to give them trauma-informed care. In fact, asking them to recount the details of their trauma even once is incredibly re-traumatizing for most of us. Let people know that if they want to share, you are there to listen, but that they don't have to share. Trauma-informed care isn't about knowing the dirty details from the lives of every one of your patients. It's about making a space and designing services that feel safe to everybody. Next slide. So when we're thinking about reproductive harm reduction, we can integrate everything all at once, or you can just start with a little bit at a time. Again, I want to emphasize doulas and birth workers, so needed for literally everyone, and especially for our people. We as public health workers, we have a voice, and we need to advocate at the local, city, state, and country and world level for better policy. Because what's happening is these lawmakers, they don't know what they're doing because we're not telling them. They're looking to us to inform their policies because that's our job, right? So we need to get involved, whether it's writing a little blurb email to your representatives or whether it's going to the Capitol and banging down doors. Reproductive harm reduction centralizes impacted people and also pays them for their expertise. I love peer programs, but not when peers are considered to be a second tier of employment. People with lived experience need to be in all levels of our organizations. They need to be not just at the table, but leading the meeting. They need to have lots of opportunities for advancement, including to the top of our organizations, executive directors, and what have you. We also need to pay people with lived experience appropriately. I would say more than other staff if we're going to have two tiers, because regular staff is not opening their heart and soul every day. Regular staff is not doing nearly as much emotional labor as people with lived experience, and they need to be paid for that. We also want to include abortion, gender affirming care, adoption. All of these are part of a reproductive justice framework that prioritizes bodily autonomy and the right to have children when we want, to not have children, and to raise the children we do have in supportive and healthy environments. Next slide. So really briefly, I'm going to go over just some okay, we did the 5,000-foot view. How do you do it? When you're trying to get individuals on board with harm reduction, focus on humanity first and facts second, because we all like to think that we're totally like Spock, Vulcan, logical beings, and we make all decisions based on logic, but none of us do. All of us make our decisions based on our guts and our emotions. So focus on the kinds of connections you can make on those values. There's a couple links there, and they're also at the end of the slides. The NarcoFem story share and this beautiful piece by Elizabeth Brico. We need to share stories so that people can put themselves in someone else's shoes and really empathize. I want to disrupt the assumption that we are exceptional. And what I mean by that is that most of us have dabbled, right? Or maybe even used more drugs than we particularly wanted to at a certain point and then grew out of it or something like that. We are not the exception. That is typical substance use. What is visible to us is not what is typical. We're seeing the people that are struggling the hardest and that need the most help. But typical substance use is not like what we see on TV. We want to meet our colleagues where we're at and also embrace humility. People don't really want to know what you know until they see you as somebody who's safe and who is pleasant to talk to. So oftentimes it can be tempting to get all high and mighty and bristle and speak truth to power, which absolutely there's a place for that. But also harm reduction is about meeting people where they're at and celebrating small changes. We'd love to change the world all at once, but it's probably not going to happen. Next slide. Next slide is about strategies for teams. Juan, there we go. And so we want to focus on behaviors that foster a welcoming environment, both for team members as well as for clients and patients. You could do a regular swear jar where every time you say something rude about people who use drugs, you put money in. But I like the idea of a reverse swear jar, where every time one team member recognizes another team member for using affirming language, or whatever the focus is that week, you put a card in a jar for a raffle or something. You could do Poppy Awards. I don't know if there are many nurses out there. There's like Daisy Awards where you can recommend a nurse for a little award, and it usually comes with just some recognition. We could rename those Poppy Awards, and because the opium poppy, right? You can talk about the office plant or fish as if they were a person who uses drugs. This can be really helpful to just practice without having any danger of hurting the plant or fish's feelings. Multidisciplinary case reviews can be extremely helpful, and they can be done very quickly during staff meetings. And most importantly, promote open discussion by not pointing the finger and calling out bad behavior, but recognizing that we're all in these teams and in these professions because we want to do good. And once we recognize that, then it's so much easier to have those hard conversations about how exactly to do that. Next slide, and last one. So when we're thinking about systems, we want to focus on access, equity, and patient experience or client experience. We need written policies. We also need to make sure that what is written is actually semi-close to what happens in real life. So with those policies, we also need to do implementation and evaluation. Ethical data collection is vital. I don't have time to go into it, but look at community-based research protocols. Staff support, meaning money. Everyone loves a pizza party, but most of us would probably prefer money. And when we're doing the evaluation, we need to seek out systemic bias in impact. The deal with bias, especially systemic bias, is that it's often invisible to those of us who perpetuate it. So we're not looking to see if the written policy is racist. We're looking to see if the impact of the written policy is racist. And finally, and most importantly, engage patients and the people that are served and their families and communities in every step. That is creation of policies, implementation, and evaluation. And of course, pay them money for their time. And that's it for me. There's a couple more slides that you can cycle through quickly, Juan, if you want to, but those should be available for everybody, and we'll do questions at the end. Thank you.
Holy smokes. Thank you so much. That's so great. And next we're going to have Essence Harrison from UNC. And thank you all so much. This has been so great. Yeah, Essence, over to you.
Awesome. Thank you. Again, I'm Essence Hairston. I am the Director of Community Engagement and Integrated Treatment Services here at the UNC Horizons program. Today, I will be talking about recovery and reentry. So substance use during the perinatal period and care engagement. Next slide. So Horizons provide comprehensive substance use disorder addiction treatment for pregnant, postpartum, and parenting people and women and their children impacted by substance use, violence, trauma, as well as incarceration. Next slide. So I'll highlight three things today. So I'll provide a very brief overview of perinatal maternal substance use, identify how the historical treatment of substance use during pregnancy impacts care engagement today, and then also identify opportunities to promote care engagement and healing. So how do we shift from intergenerational trauma to intergenerational resilience and healing? Next slide. So from 1999 to 2017, we noticed this increase of drug overdose among women aged 30 to 64 years. Most of those overdoses involved opioid use, synthetics, so thinking about fentanyl, carfentanil, heroin, as well as prescription medications. We also noticed increase in benzodiazepines, so thinking about Xanax, Valiums, and as well as cocaine and antidepressant medication. During the COVID-19 pandemic, we noticed that pregnant patients were least likely to access medication for opioid use disorder than non-pregnant patients. And during the time, what we saw in North Carolina, we noticed that access to treatment was already limited to this population. And so with the pandemic, services were either terminated or reduced, or not able to actually address the barriers needed, such as childcare and transportation, to promote care retention. Next slide. So when we're looking at substance use during pregnancy, here's some information issued from SAMHSA in 2018. So despite the increase of opioid-related injuries and/or deaths, the most common drugs today among non-pregnant and pregnant people and/or women continues to be alcohol and tobacco. Specifically, when we're thinking about substance use during pregnancy, it's important for us to realize that as care providers, that is an opportunity for interventions. So pregnancy promotes a buffer, this protective factor, so we can intervene. And so it's important that when pregnant people and/or women enter into our healthcare settings, that we do verbal screenings. And I'm very intentional about using the term screening, but verbal screening for all individuals. And those verbal screenings, this is specifically related to the 4 Ps here. So asking about substance use prior to pregnancy, asking about familial substance use, and then also asking about substance use among partners and peers. Next slide. Next slide. So when we're thinking about substance use pregnancy in prison, specifically here in North Carolina, we noticed a increase among pregnant people and women being in prison, specifically 60% in a 3-year time frame. During the 2021-2022 fiscal year, 132 pregnant people and/or women met DSM-5 criteria of having an opioid use disorder, and were enrolled in perinatal substance use disorder counseling at the women's prison here in Raleigh. 1 in 4 pregnant people in U.S. prisons meet DSM-5 criteria of having an opioid use disorder. So when we're thinking about prisons, we're thinking both state and federal prisons. Specifically here in North Carolina, we're seeing 1 in 2 pregnant people housed in our women's prison meet the DSM-5 criteria for opioid use disorders. And at the time of release, looking at some qualitative findings, we're seeing that individuals at the time of release are engaging in unprotected sex or survival sex and/or transactional sex practices and injection drug use within days of release. And I can't speak on other states, but for North Carolina, individuals who are leaving a jail in our prison are 74 times more likely than the general population to experience a fatal overdose within those first 2 weeks. So 74 times more likely to experience an opioid-related overdose upon release here in North Carolina. Next slide. So North Carolina, we are fortunate to have a variety of treatment programs for pregnant and parenting people and women. So we have our ADACs, which your traditional inpatient detox or withdrawal management units. Out of those three, we have two that actually allow individuals to have withdrawal management and oversee that throughout like 6 months of that postpartum phase. We also have what we call the North Carolina Perinatal Maternal Substance Abuse and CASA Works for Families initiatives. There's about 28 programs located in 13 counties throughout the state of North Carolina, and that provides a variety of outpatient, enhanced outpatient services, as well as residential treatment programs. So we'll talk a little bit about those later on. And then we also have the traditional outpatient programs, such as your opioid treatment programs, that offers daily dosing of methadone and or buprenorphine, and then your OBOTs, as what we call the office-based treatment, where providers prescribes buprenorphine. Next slide. In the next couple of slides, we'll talk about trauma, stigma, and discrimination. Next slide. So SAMHSA defines trauma as a single event or series of events or circumstances. It could be related to physical, emotional, and or verbal assault, abuse, and or neglect. It could be witnessing acts of violence or harm to others, accidents, natural disasters, combat, as well as incarceration. It is important to know that a particular event may be experienced as traumatic for one individual, but not for another. Next slide. So the effects of trauma can be both short and long-lasting effects. Typically, what we see in practice of long-lasting adverse effects is typically we'll see individuals' inability to cope with normal stresses or stressors in terms of daily living. The inability to trust and benefit from relationships because of that provider mistrust and previous experiences, manage emotions, memory, attention, thinking, and behavior. And then also seeing that traumatic experiences can lead to this constant state of arousal or hypervigilance, what we in practice like to call that fight, flight, freeze, and fawn response that typically will physically, mentally, emotionally wears on a person. So that mind-body connection is disrupted. Next slide. So trauma history for the individuals that we serve here at Horizons, about 53% report experiencing homelessness at least once, 77% report experiencing emotional abuse, 50% report experiencing physical abuse, 67% report experiencing sexual assault, with the average age of the first sexual assault at the age of 9. 71% reported experience of domestic violence, as well as 15% reported forced to engage in sex work and or trafficked. And about 86% of new clients reported to at least one form of interpersonal violence at the time of intake. Next slide. So I won't go too much into stigma and discrimination, but these are two examples in terms of specifically talking about stigma and discrimination, because that is a whole topic in itself. But specifically, when we're thinking about stigma, we're thinking about the complex of attitudes, beliefs, behaviors, and structures that typically negatively impact individuals' access to care or deters individuals from care, and it shows up in bias, discriminatory practices, etc. And then, of course, discrimination, the unfair treatment of people based off of their identities, typically minoritized or oppressive identities associated by society, so race, gender, age, sexual orientation, and or pregnancy status. Next slide. So when I'm talking about the work that we're doing, I always find it important for me to talk about the historical context and what that means in terms of management of substance use during the perinatal period, and why it's such a struggle for individuals, for us to get individuals to come into care But there's a reason, or a variety of reasons for that, right? And so here in North Carolina, and it's not just North Carolina, it's actually a judicial process throughout the country. So safekeeping is the involuntary movement of a person from a county jail to prison, typically for pregnancy, mental health, complex medical conditions. Specifically for this PowerPoint, when you hear me say safekeeping, I'm specifically referring to a pregnant person or a woman. Safekeeping originated during the Reconstruction era as a form of discipline and enslavement of Black men and women throughout the southern states. And so safekeeping in practice here in North Carolina is a pregnant person will enter into a jail. That jail is unable or not equipped to meet the needs of this pregnant person. And that pregnant person is then involuntarily moved from that county jail, despite not being convicted, to the women's prison. And so I want you to navigate this this journey with me, this history as we go from the Reconstruction era. Of course, there was some time in between, but now we're thinking about the war on drugs, which Joel said beautifully was actually a war on people. And so when we're thinking about the 1980s, those two things, safekeeping in the war on people, have contributed significantly to mass incarceration and also maternal incarceration. Well, Essence, why is this important? Next slide. I say that this is important because during the 80s, what would happen if a pregnant person showed up to a healthcare clinic and indicated a history of substance use or interest in wanting treatment? That healthcare clinic will pick up the phone, call the local law enforcement, and the local law enforcement will get in their car, drive over to the healthcare clinics, and transport that person to a local jail. So during 1985, 1995, it was documented that over 200 pregnant people or women in 31 states interfaced with the legal system due to their substance use. This is just what was documented. I'm pretty sure we know that more individuals interface with the legal system. We know that Black and brown women in the US are 10 times more likely to face imprisonment due to drug-related charges. And then this use of the non-evidence-based moral model of addiction has this significant impact as well. So when we're thinking about safekeeping, when we're thinking about structural racism, and then when we're thinking about the treatment in terms of pregnancy status, and now the outcome, that impact of this moral model, like there's a moral failing, and that in order to address substance use is through incarceration, that continues to have an impact on the population that we work with. And so although we are not calling local law enforcement, right, to come to clinics and transporting folks to jails, what is happening is the use of child welfare. And child welfare is still a judicial process, a legal intervention, and continues to serve as the primary intervention to addressing substance use during pregnancy. Next slide. So what are the long-term effects of stigma, trauma, discrimination? So what we see is the lack of trust among the agency and provider. We're also seeing the limited understanding of treatment challenges and barriers. We see incarceration. We see increased caregiver infant separation. We see increased child abuse charges due to unmanaged substance use. And we also see that pregnant people who experience incarceration during pregnancy will be referred to child welfare. That is a standard protocol. And also we see the lack of inclusivity. So when we're thinking about recovery and we're thinking about reentry, recovery at the time when they were establishing addiction treatment, it was with the idea to treat men or male identified people. And so now we need to expand that, right? So to be more inclusive to women or female identified people. And we're seeing that on the reentry side because prisons were designed for men, male or male identified people. And so guess what? Reentry services are meeting that population's needs. So we're seeing this lack of inclusivity. We're seeing the lack of specialized services that also continues to perpetuate that stigma and also that invisibility because interventions are not addressing this population at hand. Next slide. So the next couple of slides, I'll talk to you a little bit about using trauma responsive principles to guide or to increase care engagement and to promote healing. So what we're doing here at Horizons, next slide. So the first important thing I like to discuss is kind of moving from trauma informed to trauma responsive. So we're thinking about trauma informed. We're thinking about understanding the prevalence of trauma in our population, taking that information and recognizing, like Joel mentioned, you do not have to know someone's trauma history to actually be informed about trauma and and knowing how to centralize that those traumatic experiences to promote care. And then trauma, the third part of that trauma-informed care is responding to that knowledge. And so we can only respond to that knowledge when we know the history, when we know the prevalence and the impact. And so I would encourage individuals to move from trauma-informed to trauma-responsive care, because at this point, we should now be responding to trauma in a healthier way or in a compassionate way. And so what does that mean? It means to minimize victimization and re-victimization. We do not want to re-traumatize. We want to facilitate recovery and healing and empower. We want to respect an individual's choice and control over their recovery, their reentry journey, as well as their body. We want to establish goals that the client or the individual has identified for them. We also want to look at it from a strengths-based approach and reframing adaptive behavior as positive coping. And also recognizing that symptoms are adaptations to traumatic experiences. And then also wanting providers to meet the person, the woman, where she is in her life experience and what recovery means to that individual. Next slide. So I'll provide a couple of some information about a couple of services that we provide. So our prenatal postnatal clinics, comprehensive care coordination, our gender responsive reentry services, residential programming, and transportation and childcare. Next slide. So each year we serve about 200 to 250 women, including about 75 families in our residential treatment programs. Average age is about 30 years old. 50% indicate pregnant at intake, and 90% have at least one child under the age of 18. Most of our patients that we work with are covered by Medicaid and or uninsured. The most common diagnosis is opioid use disorders, but we know that oftentimes the population that we work with engage in some polysubstance use, and 95% have been arrested at least once, 70% convicted, and 55% have experienced incarceration. Next slide. I'm going to also speed it up so I can be mindful of time. I've been keeping my timer here. So our prenatal clinics are an integrated approach where we have a provider, therapist, and a case manager. We are able to have a office environment where our providers do not have to fit into that 15 and 20-minute window, but then also recognizing that the transportation and childcare, they're barriers. And so our providers are like, when you get here, we will see you. And so counseling and case management occurs before and after appointments. And then, of course, access to medication for opioid use and alcohol use disorder. Next slide. Similar to our outpatient clinic, we also help facilitate the first integrated prenatal subclinic at a women's prison. This is facilitated by Dr. Andrea Canetto. The purpose of the clinic is to dedicate to the care of pregnant people with a substance use disorder at a women's prison, and the setup is similar. So there's a case manager and a therapist that provides counseling before and or after visits. Next slide. Before and or after visits that allows us to promote this gender responsive reentry, but a strong continuity of care services. So I will leave with the GENIS project, but 2019, we awarded funding to increase reentry services in the state of North Carolina. The GENIS project was created after a graduate of the Horizons program. Upon graduation, Jenna made the decision to return home. Unfortunately, Jenna reconnected with old people, places, and things and accrued new charges. At the time of Jenna's release, she ran into my colleague and wrote a note and said, "I need some help. Can you get me back into Horizons?" Before we could call Jenna to set up an appointment to re-engage services, Jenna experienced a fatal overdose within 24 hours upon release. And so what we did along with support of Jenna's family was to identify ways that we could reduce this from happening in the future. And so upon our program completion, we provided, upon 6 months of providing comprehensive care or coordination for pregnant and postpartum people here in the state, we were able to work with 132 unduplicated pregnant people. Only 1.5% returned to illicit substances. And at the end of this 2-year pilot, no reports of opioid-related deaths and or injuries. We expanded from 1 prison to 3 prisons. Next slide. And also supported a transition from a federal prison. I will continue to move us along. This slide is just some information about our 3 prisons. So we went from that 1 prison to 3 prisons in doing that interdisciplinary team approach. So we have case managers throughout Western North Carolina and the eastern part of North Carolina, where we continue to reduce opioid-related injuries and deaths. Next slide. That also created our recovery-supported transitional housing model. So when we're thinking about care, we're thinking about access. We cannot talk about access to treatment without addressing those structural and social drivers of health, including health, racial, and social inequities. And so we are fortunate to have 5 fully furnished apartments and a housing manager here in our Wake County that provides culturally responsive physical and behavioral health services and also referrals. So working with birthing and postpartum doulas, the local health departments, as well as other community providers based off of the individuals, as well as peer support specialists. Next slide. This is a little information about our residential treatment program. So treatment is very different from housing. Treatment, we are able to serve 30 families at a time. They're also fully furnished apartments in a confidential apartment complex. We look at our residential and our housing models as it's not just having someone placed, but having somewhere go into their own to feel hope and thrive. And then also access to individual and group treatment, medication, transportation. Next slide. I think that should be, I was going to say, I think that should be it. So sorry. And then also we have a treatment for children. So we do focus on dyad care. So looking at the families and intervening on the family level. We have a child therapist and a child psychologist that leads our early intervention services. We have a 5-star child care, but also provides informal child care and psychiatry. Next slide. And this is just a table that shows the importance of language and the power of language and how we can show up in our practice and what we can do to engage, increase engagement of care. And of course, language changes over time, but we either have the choice to increase care engagement or deter individuals for engaging in care. And I think that's the last slide. And this is typically folks want to know, well, how much are you saving the state? I know this is not folks on this call, but our services saves North Carolina $3.3 million each year. We can keep on going.
Thank you so much, Essence. Awesome. And our final speaker is going to be Cindy Floyd from Citrus County, Florida. And she'll be on, she's going to share her screen with us. And then, you know, this is such a rich conversation. I think we'll have a little less time for Q&A than we anticipated. I will ask that folks, if you have questions, let's go ahead and put them in the chat. And so we can hopefully get to those or get to those after the session. And Cindy, you are free to share your screen. And you're muted as well. I will then while Cindy works on getting that done, I'm going to just put a few polling questions in here. So we will just ask a quick polling question. Amazing. Y'all are so quick at responding. Awesome. Beautiful. I'll end this in 10 seconds. Perfect.
And is my PowerPoint up, or can you see it?
Your PowerPoint is up and we are ready to go.
Perfect. Good.
Thank you all.
All right. My name is Cindy Floyd. I'm going to talk to you a little bit. I work at the Florida Department of Health, and I'm going to talk to you about medication-assisted treatment for substance use disorder in pregnancy. Again, I'm Cindy Floyd. I am a nurse practitioner and a board-certified midwife. I've been in healthcare for over 30 years, and I am with the Florida Department of Health in Citrus County. So I'm just going to kind of briefly go through some of this because we have all had this information already, but it just talks about the opioid epidemic in pregnancy. This here is from 2019. 14 to 22% had filled a prescription during pregnancy. 1 in 5 pregnant women were getting opioids and taking opioids in pregnancy. Again, this is in 2019. We know that this has increased significantly, especially since 2020. So just to look at the deaths occurring after 20 weeks, we were comparing in our county, we were comparing Florida stats with Citrus County. And if you see at the 2018, we were way, I mean, almost doubled what the state was doing, the average. And then if you look over here on 2020, we did put some programs into place, one of those being the programs I'm going to talk to you about. We also introduced back to sleep and those sorts of things. So our numbers came down, declined significantly, which we were very happy with that. So just to give you a brief overview, entry into prenatal care in 2017, we were looking at, again, Citrus County versus Florida. compared to first trimester, second trimester, and third trimester, we were lower, not significantly, but lower for the first trimester, but higher for the second. And we knew that substance use disorder did play some role in that as well. So I decided to, when I came on board here as a nurse practitioner and started seeing obstetrical clients here, I wanted to go over and just kind of get a brief overview of how many of my patients had positive screens when they came in. And just to give a brief overview, everyone that comes in for prenatal care gets a drug screen. We don't want to be choosing and be picking out people that we're going to screen. So everyone gets screened. They do sign a consent for this as well. So they are aware of this, but we do screen everyone. And in this drug screen, these screens that we were doing, we came up with 38% tested positive for some type of controlled substances, and nicotine and alcohol were not even included. And I do agree that nicotine and alcohol is probably going to be one of the nicotine definitely is going to be the higher. So some of the barriers that we were finding for these clients to come in and get care was fear of the baby being removed. That was the biggest one. Location, transportation, access to a provider. Definitely a lack of MAT providers. This MAT stands for medication assisted treatment. We were definitely lacking that, with only three possible obstetrical places that you could receive OB care. 2 were private clinics, and then here at the health department, it was very limited on who would even see anyone that had a substance use disorder at all. And if they were receiving MAT from out of county, because that's what they were having to do, was actually go out of county, they and became pregnant, and were seeing one of the private entities in the county, they were dismissed from the practice. So this was one of the patients, or actually this is the phone call I got from one of the practices in the county. It said, spoke with the patient, she called crying, stating she needed help. She had been to the ER twice. They advised the patient that her drug screen did come back positive. She's too high risk for this clinic, and she would be transferred to the Citrus County Health Department. So that was a general thing that was very common in the county. We know that withdrawal is not the answer. Risk of opioid withdrawals can cause preterm delivery, premature rupture membranes, IUGR, SGR, and that's intrauterine growth restrictions, small for gestational age, convulsions, babies can seize in utero, fetal death, and a very high risk of relapse with a high risk of overdose. What ends up happening, however, unfortunately, is they end up with no prenatal care and no follow-up appointments. And just to tie this in a little bit with STDs and our topic, one of our topics of syphilis, we find that a lot of times these patients who have a substance use disorder also are can be doing various acts to gain different substances off the streets, and some of those can cause some sexual high risk behaviors. During those times, a lot of these clients that come in are positive for some type of STI, as sexually transmitted infection. This, I just added some stats from a Baltimore STD clinic, just talks about how much they were getting when they were having people. It said over a third of women with primary and secondary syphilis reported sex while intoxicated or on drugs, and 9.5% have exchanged sex for drugs or money. So we knew that was one of the complications, one added complication. So substance use in persons with congenital syphilis and pregnancy outcome was nearly double that of those that are a non-congenital syphilis pregnancy outcome. and 6 times more likely to report illicit use of opioids, and 4 times as likely to report using other illicit substances during pregnancy. And approximately half who used substances during pregnancy had a congenital syphilis pregnancy outcome with late or no prenatal care. One of the things that I'm just going to add into this too, one of the steps that we took as a state is one of the testing that we do for syphilis is called RPR, but we were getting so many false negatives, and with the amount of pregnant clients that were coming in with substance use disorder, some of these the RPRs we were getting a lot of false negatives. And so these moms were actually had been positive for syphilis. So they actually combined a confirmatory test with this. So now all pregnant clients that come in are tested with a confirmatory for syphilis, just because the rate of congenital syphilis had increased so drastically. So syphilis complications up to 40% that are untreated can actually result in stillborn or die from an infection as newborns. They can have seizures, infections, deformities, blindness, and hearing impairments, just to name a few. This is Florida, because I am from Florida. I know we're all from all over the country here, nation. So just from Florida, congenital syphilis case reports increased 82%. This was mind-blowing to me because I hadn't looked at this in a while, and I was, blown away a little bit by this. And you can look, this is just from 2017 to 2021. And we're in 2023 now. So reported cases of adult syphilis increased from 8,954 to 16,438 in 2021. And childbearing was 63% increase. This resulted in 72 syphilitic stillbirths. So what we wanted to do is we wanted to try to address the substance use, and obviously when we address those, we can address some other things as well. And so what we did was we took steps to try to see what programs we could add in the county. In 2018, we started a substance exposed newborn task force. And in 2019, we engaged mental health providers on substance use disorder and options for treatment. We did again, as I had previously said, that we lacked the local providers, and we were actually sending these patients, we were trying to send them out of county. That didn't work very well. There was definitely an issue with transportation. We were in a rural area, so transportation was definitely an issue. I wanted to add the ACOG recommendations that the use of MAT during pregnancy is a recommended best practice for care of pregnant women with opioid use disorders. So why we wanted to do it here, we have many different other programs here at the health department. We do a diabetic clinic, HIV, all different sorts of epidemiology, and we treat the entire disease process. We do consider substance use disorder as a disorder, and not as the previous speakers have discussed. We're trying to change the language and use it as a disorder, what it is. And so we did show some evidence-based practice regarding maternal fetal well-being and the need for the intervention to help, these clients that come in. And we provided the recommendations from the U.S. Surgeon General, SAMHSA, ACOG, and American Academy of Pediatrics. So this was something that we had to kind of figure out a way to get around. We are a public health department. We're one of maybe, I think, 3 in the state of Florida, 2 or 3, one of 2 or 3 that still do prenatal care. Most of the health departments do not do that. Doesn't even do prenatal care, much less add what we wanted to, which was medication assisted treatment, that being buprenorphine or Subutex, not Suboxone, Subutex. So I have to say we have a great administrator. Me and some of my colleagues went to him and stressed how important we felt this need was. We wanted a complete program. We wanted these clients that came in for prenatal care to come in, get their prenatal care, medication assisted treatment if needed, and their counseling as well, which is why we incorporated LifeStream, which is one of the mental health facilities that we have here in the county. So he did a fantastic job, because he was able to go to Tallahassee and show them how incorporating this would be incorporating totality of care, a holistic care, and meeting these clients where they are. So we did receive approval in 2019 to prescribe buprenorphine at for the prenatal clients who are affected by substance use disorder here at the health department. And we take very good pride in being able to do that. So where we started in 2017, I started attending. This became a passion of mine. I really just, my heart went out to so many of our clients who really wanted help, and they had nowhere to turn and nowhere to go. And so I started attending some of the NAS meetings, the neonatal abstinence summits. We started the SEN in 2018. We've received our first grant in 2019, and I completed my extensive training and certification to provide MAT in 2019. And in 2020, we had approval for providing prenatal clients with the medication, and we developed a partnership again with LifeStream. So this is our team here. This is Allison, is over to the right in the purple, and she's my nurse, and my tech Darlene. So we all had a passion to do this. So our first prenatal and substance use disorder patient was May of 2020. And that, I don't know, this, some ways it seems like a long time ago, and other ways not so much. We saw 8 people in 2020, 9 in 2021. As of this month of this year, 34 clients had participated in the program. 20 had completed the program. 14 either did not return to the clinic or to the program. They were dismissed, usually because they don't return or don't. And we do still offer prenatal care. In fact, I do have a couple of my clients who decided that wasn't for them. And I still encourage that they continue their prenatal care, and they still do come in for their prenatal care. We stress, and extremely stress, the importance that there is no judgment here. We are not here to judge anyone. We are only here to provide the care that they need. And whether that be with medication assisted treatment and prenatal care and counseling, or just prenatal care, whichever way they want to go, we're here, and we want them to know that we're here for them for that. This is a video I wanted to play.
Well, it means a lot. They actually took me in to help me. I've seen 4 or 5 other doctors before I got here, and they kept bouncing me around. So it's actually a lot. They took me in, and it's helped me out a lot. All the prenatal care that I need. I can hear the baby's heartbeat, and I'm getting treatment for an addiction. Better. They're very not judgmental. They don't judge at all. They're very caring, and they listen. They actually seem like they care. From the other doctors, they kind of look down on you and just don't want nothing to do with you. It means the world. That way, I'm don't want to lose my baby. I don't want it taken away. I want it to be healthy more than anything. I want it taken care of more than healthy. And to let me come in and get it treated and not be like stuck in a hospital or threatened with the baby, it means a lot. Well, it means a lot. They actually took me in to help me. I've seen 4 or 5 other doctors before I got here, and they kept bouncing me around.
I think I need to get off.
Awesome. And Cindy, just to let you know that we have about 4 minutes left overall.
They took me in and it's helped me out
All
a
right,
lot.
let me see if I can get off of this.
Okay. And while we do that, I'm going to go ahead and launch into our last questions here. So we are going to launch this question. And give folks an opportunity to answer that. And Cindy, I'm sorry, you can go ahead and.
Yeah, I'm kind of just finishing up here. Just our goals that we're looking at: prevention, reducing alcohol, tobacco, ensure access to prevention and treatment, ensuring that everyone has access to health care, receive early and consistent prenatal care, and safeguard against discrimination and stigmatization. One of the things that we do here in the clinic is every room has a TV with a video talking about how we're trying to do our best to help lower the stigmatization and discrimination against any person that has a substance use disorder or opioid use disorder. And where we go from here is one of the things that we are trying to look into. I know one of the speakers before me was talking about incarcerations, and we would love to be able to get into that. And we've been trying to work on that as well. We definitely still need to do better. We have a long ways to go yet. So, but together is where we want to be. No judgment, just help. And I will do it.
Thank you so much. There was one question in the poll, and it was, what happens if patients do not consent for drug screen on intake? And just as a question for that, is that something that's mandated by the state of Florida, that there's drug testing?
No, it's not mandated at all. And one of the other things I wanted to point out too is in the state of Florida, we do not report drug use and pregnancy. That is, state of Florida does not report drug use. The baby actually has to be born, and then the baby, even if the baby is born and the mom tests positive at birth and the baby is negative, then there is no DCF calls or nothing. The only way that DCF is notified is when if the baby in itself is test positive. And like I tell all of our clients, you can refuse anything. There is nothing that, we don't force anybody to do anything. So anything can be refused. So if they refuse the drug screen, which we have had people do that, say, I don't want to do it, then that's fine. We still want you to come in for prenatal care. Now for the MAT program, it is a requirement for my program. The reason being is because fentanyl is a big issue, and I cannot give buprenorphine if someone is regularly using fentanyl, just due to the fact of a high incidence of overdose and death. So that's mainly why we do drug screens, is if they're going to be in the MAT, they are screened regularly and they do sign that consent. If they don't sign the consent for the drug screens and they want to be in the MAT program, that would be a problem, only because I'm the one that's prescribing the buprenorphine. Does that answer?
I believe it does. And any follow-up questions that folks have, please just let us know. And I just want to thank all of our speakers today. And I want to thank everybody who's in the chat. There's some amazing things in there. I'm going to make sure we copy this chat because there are so many great resources that were put in there. I do, just as a very quick wrap, I know we're right there at time. We wanted to have an engaging conversation, but this is such a rich topic area. Please do put in the poll, like follow-up questions that you may have, other areas that you want to explore further. That means so much to us with planning out future events. I do just want to plug that there are still 3 more webinars in this series to come. So our next one, let me find my notes here. Our next one is going to be May 30th, and that's going to be briefly discussing disparities, interconnectedness of mental health, substance use, housing, and other social determinants of health with current syphilis outbreaks and provide examples. We also want to announce that NACHO is partnering, or excuse me, we want to announce 2 related funding opportunities to fund the evaluation of harm reduction in STI services. One is for organizations who primarily provide STI service for STI service providers, and another that are primarily for harm reduction service providers. We will send a follow-up email with some information there. I'm going to put really quickly in the chat, our incredible rich chat. We've had so much going on there. Oh, Kirsten is ahead of the game on that. And then we also wanted to let y'all know that NACHO is also launching a webinar series on opioid settlement and navigating that for local health departments and their partners. There are so many ways that has been both an incredible boon for the types of services that harm reduction and local health departments are able to provide. We also know that has been a source of opaqueness. So we want to provide some folks with some information and resources on that. We will also have technical assistance office hours for that as well. And yeah, we just appreciate all of you for coming. I am going to put in my email here if you have other questions or follow-up that you didn't get a chance to ask, or things that come up afterwards as an aha moment. Please feel free to email after. And I just want to again thank all of our speakers today. It's much appreciated.
Thank you. Thank you for having us.
Thank you so much. Thank you. And thank you everyone who attended. It's so intimidating, but really great. Awesome.
Thank you so much. I
Thank you.
loved hearing from the other speakers as well. And the chat has been so
The chat was
distracting. I love
incredible.
it.
What an amazing chat.
Very
awesome.
much.
And thank you all again.
Thank you.
Thank you.